My name is Caroline Lozer. I'm with the Lewin Group. This is the second webinar in the 2017 Geriatric Competent Care webinar series. The audio portion of the presentation will automatically stream through your computer. However, phone dial-in information is available upon request in the chat feature if you do not receive a phone line. Today's session will include a 60-minute presenter-led discussion, followed up with 30 minutes for a discussion among the presenters and participants. This session will be recorded, and a video replay, as well as the Q&A, will also be available at https://www.resourcesforintegratedcare.com. If you are looking for a copy of today's slides, you can also find them on this website. This webinar is presented in conjunction with the American Geriatric Society, Community Catalyst, and the Lewin Group, and supported through the Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. Continuing medical, MMCO is developing technical assistance and actionable tools based on successful innovations in care models, such as this webinar series. To learn more about current efforts and resources, please visit our website or follow us on Twitter for more details. Our Twitter handle is @integrate_care. At this time, I'd like to introduce our moderator. Carol Regan is a Senior Advisor to Community Catalyst Center for Consumer Engagement and Health Innovation and has over 30 years of experience with national and state-based public policy and healthcare advocacy organizations. Carol?
Hi, thanks, Caroline. Can you hear me okay?
Loud and clear.
Great, thanks. So thank you on behalf of Community Catalyst. We are so pleased to continue this wonderful partnership with MMCO, the Lewin Group, and the American Geriatric Society to educate and promote good models of care for older adults. Community Catalyst is a national nonprofit advocacy organization working to really build the consumer and community leadership that's required to transform the American healthcare system. And our belief is that happens when consumers are really fully engaged and have an organized voice. Our first priority is quality, affordable healthcare for all. And we're also very committed to transforming the healthcare system through promoting, through our Center for Consumer Engagement and Health Innovation, good models for care models for older adults. And this geriatric competent care series we've been working on for now our 4th year with our partners is part of that effort. So thank you all for coming today. What I'm going to do is introduce all of our speakers in the beginning so that they can just move through their slides. Our focus is going to be on first talking about key diagnostic features, secondly on prevention and management, and third on the impact on individuals and families. And we're delighted to also have a family caregiver share her experience with us today. So we're going to start off with Dr. Melinda Lance, who is the Chief of Geriatric Psychiatry and Inpatient Psychiatry at the Mount Sinai Beth Israel. She's a Program Director of Geriatric Psychiatry Fellowship Program and Associate Professor of Psychiatry, and she has served as an officer and member of the Board of Directors of the American Association of Geriatric Psychiatry. She's the author of numerous publications and presentations in the area of dementia care and late-life mental illness. Then we have Dr. Jerry Hall, who's one of the pioneers in dementia care. Starting in 1978, she devoted her career to non-pharmacological management of Alzheimer's disease and related disorders. She developed and researched the progressively lowered stress threshold model for planning and evaluating care in Alzheimer-type dementias, which has been disseminated throughout the U.S. and many other countries. About 8 years ago, she was noted that we weren't really meeting the needs of families affected by non-Alzheimer dementias, especially Lewy-body disease and frontotemporal degeneration. So she has spent the last 8 years specializing in these special needs patients. Jerry also sees clients and families in clinics, facilitates support groups, conducts research, and speaks on these poorly understood and often overlooked conditions. Our third speaker will be Rebecca Wilson, who is a social worker and a dementia care specialist, trainer, and aging care coach with 14 years of experience in elder care services, including hospice, home health care, assisted living, and care management. In these arenas, she has used her specialties in teaching, community outreach, marketing, and developing innovative strategies for providing comfort care for seniors and their care partners. She's presented at local, state, and national conferences as a trainer on Alzheimer's disease, frontotemporal dementia, behavior management, navigating transitions, and other really key caregiving topics. She serves as a dementia care coach, mentoring care partners in developing individualized non-pharmacological interventions and innovative care solutions. She has dedicated her career to improving the care for older adults, and she considers it an honor to help those navigating the aging process. And finally, we have Sharon Hall, who currently is a family caregiver, and she will share her personal experiences dealing with these non-Alzheimer's dementias. So you can see we have an incredible panel. So let me turn it over now to some polls we'll do in the beginning, and then we can start our official program. So as the poll is being prepared, remember, use your clicks in this to which best describes your professional area, and just choose one. Give you another 3 or 4 seconds. Add your vote here. Very good. Now close the poll, and let's see our results. Okay, so we have a third of folks in social work, about 25% in medicine or nursing or other providers, which is interesting, and about 20% in health plan management. Terrific. Great. So thank you. Next poll. Okay, it takes a couple minutes to get the poll up, so just be patient with us. Okay. So this is, if you could answer this to the best of your ability, what is your primary role? How would you describe your role? And you have several options here. Great, take a couple more seconds, excuse me. Just make sure we've got everyone captured here. Great, okay, let's close up the poll and let's see what we got here. Interesting. So we have 43% are care coordinators, a really critical role, which we'll hear more about today. About 1 in 5 are clinicians, 11% administrators, and 12%, I guess, no vote here. Okay, great. We have one more poll. So as that poll is being prepared, we'll get ready to answer this one. So in what kind of setting do you work? What best describes the setting you work in? Great. Okay, take a couple more seconds to fill in this poll. Take your time. It's really helpful to know who the audience we are talking to. Okay, let's close up this poll and then we can move ahead to the presentation. So most people, half of the people work in a managed care organization, and we've got many else in other, and 15% in a community-based organization, some long-term care facilities. Great. Okay, so thank you for taking the time to share a little bit more about who our audience is, which helps us plan for the next ones. And now I'm going to turn it over to Dr. Lance to start off our program. Thanks very much.
Okay, thank you very much. It's wonderful to be here today. So I understand we have a very mixed group of clinical people in management. So what I will do is briefly go over the criteria for what a dementia is, and then focus on 3 of the more common of these unusual dementias. So if I could have the next slide. Okay, so I'm going to give just a quick overview. I gave you a lot of materials in these slides. That's all available for you. So I don't want to read them line by line. But we all know that dementias as a whole are disorders of loss and decline. So we have decline from a previous level of functioning in various domains. And in order to make a diagnosis, it requires a lot of evaluation in terms of getting a clear history from a patient, from a caregiver, from an informant, and performing assessments that may include neuropsych testing, repeat clinical assessments, and perhaps neuroimaging. And some of the dementias today, neuroimaging is of value. And that these deficits interfere with daily activities, social and occupational functioning. And some of the dementias we'll talk about today, frontotemporal, for example, is an earlier onset dementia, and patients may be employed at the time they start having symptoms. Okay, so next slide. Mild neurocognitive disorder or mild neurocognitive impairment is decline in, obviously, cognition that doesn't meet criteria for dementia. And this, for many patients and caregivers, is an unfortunate, almost kind of purgatory state in that they have objective declines, usually in memory, but they don't have declines in other domains yet. And some dementias may start out as mild cognitive impairment, and patients may stay in those states for years, and some may then go on to decline. And the dementias we talk about today often have prolonged or protracted impairment stages that often makes diagnoses difficult for patients and families. Okay, so the first of the non-Alzheimer's dementias that we'll talk about, and could I have the next slide? Thank you so much. Vascular dementia, or dementia due to cerebral vascular disease. This is where we know the cause, because in order to have vascular dementia, patients have risk factors for vascular disorders. And this is the second most common type of dementia after Alzheimer's disease. Now, these are patients who have risk factors, and they often have multiple medical problems. So these are patients with hypertension, diabetes, hyperlipidemia. Maybe they've had a history of smoking or are still smoking. And it's often identified because the patient has either a series of mini-strokes, TIAs, or an actual stroke. With the stroke-related syndromes, the cognitive loss may be more focal. Sometimes patients are more aware of their symptoms. Sometimes they're less aware. And disturbances of emotions and mood are very common and very much related to the stroke-type symptoms. The next slide, please. Vascular dementia has a great deal of care needs. The care needs are often variable, but often very high. These patients have multiple medical and physical conditions, so they may have tremendous physical care needs. They may need a lot of help with assistance of daily living right after an acute event. And the decline is also more variable. They may have long plateaus and stability in their cognition and their physical care needs after a stroke, and then they have abrupt declines related to further vascular insults such as another TIA or another stroke. It also is perplexing at times because it's common to have vascular features in Alzheimer's dementia mixed together. So caregiver burden is high related to the heavy physical care needs, heavy medical care needs, and the cognitive loss as well, as long as it's also accompanied by mood and behavior problems. Now, this is a dementia that's more common in men than women at present because men still have more cardiovascular risk factors than women. Okay, and I've included this for your reference. Neuroimaging is certainly helpful in making a diagnosis of vascular dementia because we can see the vascular disease on a CAT scan or an MRI. And we'll move on to another type of dementia. Oh, I'm sorry, and I included this in for your reference, mainly the Binswanger's type dementia. I mean, I practice in New York where maybe the clinicians just like to diagnose it, and patients often are confused by what they're referring to. And it's often important for patients and caregivers to have a clear sharing information. Binswanger's type is a type of vascular dementia. And again, I included a lot of extra material for your reference after the webinar is over. And can I have the next slide, please? Thank you so much. Lewy-body dementia is, again, a less common dementia, third or after both Alzheimer's and vascular. This has a striking clinical presentation. Lewy-body dementia is memory loss and cognitive decline that occurs in the context of motor and Parkinsonian features such as tremor or muscle stiffness. And the patients usually have prominent psychiatric symptoms as well, often hallucinations, and often the hallucinations are visible. So this is a relatively rapid onset dementia, usually later in life, and it's accompanied by a lot of unexplained symptoms that may make the diagnosis difficult in the beginning. Unsteady gait, fainting, many falls, and it generally has a more rapidly deteriorating course. Also more common in men than women, that differs it from Alzheimer's disease as well. This is a dementia of many behavioral problems, many psychiatric symptoms, and many care needs. Also, I included a slide for you of what a Lewy-body is. It's actually a dense body in the brain. Obviously, we can't make a neuropathology diagnosis prior to death, but we know that the symptoms that I described, the visual hallucinations, the motor symptoms, the cognitive decline, are very much correlated with a diagnosis later. The issue with Lewy-body dementia is that it's often accompanied by very much sensitivity to all psychiatric medications, but very prominent psychiatric symptoms that often need treatment. And let's move on, in terms of time, to frontotemporal dementia, which you'll hear a great deal about from the rest of our speakers in the panel, is a perplexing dementia often to diagnose from a physician's side. Onset is significantly earlier than the late life dementias, anywhere from 40 to 60 years of age. And the reason why that range is so variable is because it's very, very slow and very subtle in onset. And it's accompanied by atrophy by loss of tissue in two distinct areas of the brain, the frontal lobes and the temporal lobes. And those parts of the brain are associated with personality, with mood, behavior, with impulse control. And this is a slowly progressive dementia that's often misdiagnosed in the earlier stages as different psychiatric conditions, because it's often first presentations are very behavioral in nature, a lot of disinhibition, a lot of socially inappropriate behaviors in patients who in the early stages of the dementia can still perform basic daily living tasks such as math tests. Their memory might not yet be impaired. And so this is a difficult disorder to diagnose until it progresses, unfortunately. So you have prominent personality change. This is a great drain, obviously, on families. Early onset, very slow decline, a lot of behavioral problems, a lot of symptoms such as lack of recognition. They don't recognize family members anymore. And the treatment is very symptom-driven because there are no agents at all available to slow the progression. Okay, and there are subtypes. I'm sorry, could I have the next slide? There are some subtypes of frontotemporal dementia, some that have some genetic thread, and one that's classic called Pick's disease that was the first frontotemporal diagnosis. And I have a picture, if I can have the next slide, of a Pick body in the brain that's found in the frontal and temporal lobes that explain the unfortunate decline and the significant behavioral pathology of the dementia. Okay, I'm going to move on, and I'm going to give a brief overview of strategies for treatment from a pharmacological point of view. And I'll do it in an overview. I provided you with a great deal of slides with some tables of medications. But this all comes with one big caveat. We have obviously no magic pill for dementia. And we have medications that, in a carefully targeted situation, can help with certain signs and certain symptoms. In terms of treatment of the cognitive symptoms, when we look at vascular dementia and Lewy-body dementia, we do have available the cholinesterase inhibitors, 3 that are clinically used, donepezil, galantamine, and rivastigmine. They're approved for dementias actually from mild through the severe stages, but it's the outcome. It's what we really see with cholinesterase inhibitors is a slowing in the rate of decline, obviously not an improvement. It's can we slow the progression of the dementia. So this makes it very clinically frustrating. It's also difficult because the individual responses are so variable and often difficult to measure. However, the greatest efficacy, the target population, is probably those who are living in the community where we might see a delay in the need for nursing home placement. Now, this is regarding vascular and Lewy-body dementia only. Unfortunately, with frontotemporal dementia, cholinesterase inhibitors really have not been shown to be of any value, and there's a small amount of literature that shows the behavioral symptoms may worsen. So we're talking about the agents really for use in vascular and Lewy-body dementia and potentially delaying the decline. Now, rivastigmine may be more helpful in Lewy-body dementia than the other cholinesterase inhibitors based, again, on limited information. And then we have the drug memantine in a different class that's approved for use in dementia of the Alzheimer's type, but is not approved for any other types of dementia because they don't yet have evidence to show that it helps with slowing the decline. And again, frontotemporal dementia, we really avoid the cholinesterase inhibitors. And always remember, every medication obviously has side effects. With cholinesterase inhibitors, it's gastrointestinal, nausea, vomiting, potentially weight loss because of GI upset, and they can also slow heart rate. Now, moving on to pharmacologic treatment of behavioral symptoms. Again, if there's no magic pill for cognition, there's definitely no magic pill for the psychiatric symptoms. Treatment is very, very symptom-driven. We want to identify target symptoms, such as clear psychosis or distressing hallucinations. We want to choose a medication that may target those symptoms and then carefully monitor side effects. And we very much want to avoid polypharmacy. So I've given you many tables and sort of basic clinical pathways to illustrate the approach that we would take. The problem is the side effects of the medications and the risks versus the benefits. So antipsychotic agents, obviously there's seminars just on use of antipsychotic agents in dementia. One thing I can tell you, because I treat many patients who have very severe symptoms, is that use of these agents is justifiable when the patients are distressed by their psychotic symptoms or when the psychotic symptoms become clinically dangerous. Patients become paranoid and want to act on their delusions. However, those are more extreme cases, and those extreme cases come after other interventions that you'll hear about today are really exhausted, and they're not meant to be a substitute for good clinical care and good behavioral interventions. I gave you some tables of the medications as well. I do want to point out, though, that depressed mood and anxiety are very common in the more early stages of these dementias, and that antidepressants certainly could be considered. If we can help boost mood at all in these patients, we can certainly increase their comfort level, knowing that antidepressant medications also have significant side effects as well. The other issue that comes up, and if we could have the next slide, is what to do about patients who display significantly severe physical aggression to the point that people are thinking of hospitalization, and what can you do to alleviate or just diminish some of the severe physical aggression that might be dangerous to a caregiver. These are all off-label recommendations, but they are clinical consensus. Mood stabilizers may certainly help with impulsivity and aggression to a limited degree. And they certainly might diminish the behavior to a point that it can be more clinically and behaviorally managed. And that's the best use of these agents. So how can we diminish the behavior enough that our other interventions help as well? Knowing that these medications have significant side effects. Now, I also, in the next few slides, for your reference later on, I provided tables of medications and the CMS recommended guideline doses for maximum use. I know people who work in long-term care have our manuals where we have these guidelines every day. And they also included several medications and then mood stabilizers as well as the last slide that I have. And I think we have one more. Yes, and I included side effects. Please remember, all medications have side effects. We want to limit polypharmacy. And if we go to the last slide, I will use this as a way to transition you to Dr. Jerry Hall, who's going to absolutely mesmerize you with her nursing ability and her behavioral techniques. So thank you very much.
Thank you very much, Dr. Lance. It's very nice to be here today, and this is a topic I care deeply about. Like Dr. Lance, I made a lot of slides that people can use when looking at handouts because there's so much material. Next slide, please. Symptom presentation in dementia depends on several things. The first, though, and the most important, is the location of the areas of degeneration. That primarily determines the symptoms of the dementia. Pathologic changes such as Lewy bodies and comorbid conditions, but very much environmental factors make a huge difference in symptom presentation. And the next slide, please. Okay, very briefly on this. Looking at FDG PET results, look at the areas within the red circle. Within the red circle or confined area is where you would expect Alzheimer's to be. The first brain is a normal brain. The second one has mild cognitive impairment. The third one has early Alzheimer's disease, and you'll see that the blue was where the damage is, and it fits right within that red-lined area. D is frontotemporal dementia. You can see that the red-lined area is well preserved, but the front of the brain and the side is impaired. And then finally, E shows what happens when you have a very complicated dementia. The E patient has Lewy-body disease. May I have the next slide, please? If the location is different and the symptoms are different, the care needs are different. I'm going to cover Lewy-body disease and some frontotemporal lobar degeneration. Next slide, please. Next slide, please. With Lewy body disease, there are three common presentations, which is why diagnosis is sort of challenging in the beginning. Some individuals start out with a movement disorder leading to a diagnosis of Parkinson's disease and later develop dementia. Another group starts out with memory and cognitive disorders. However, it's not quite the same as Alzheimer's. It tends to fluctuate more greatly, and there are very often psychiatric symptoms associated with it. And lastly, there's a small group that first present with neuropsychiatric symptoms. The most common are hallucinations, and it's visual hallucinations, but it can be olfactory or auditory hallucinations also. Behavior problems and difficulty with complex mental activities. Next slide, please. Some of the common symptoms, the first is the one that's very often present up to 2 years prior to a person developing Lewy body disease, and that's a REM sleep disorder. The patient acts out the dreams while asleep. There's very often excessive daytime sleepiness and restless leg movement. Very often a spouse will tell you that they have to leave the bed and go into another room just because of the restlessness. Second is impaired thinking with problems with executive function, planning, processing information. Again, the memory tends to be episodic, so the patient may do very well for weeks or months at a time and then have a short period where their memory is impaired and then it gets better. So it fluctuates. Third is problems with movement, including tremors and stiffness, and a typical Parkinsonian presentation. The important thing about Lewy body dementia is very few of these people really respond to the anti-Parkinsonian medications, and as a result, the anti-Parkinson medications can make the hallucinations worse or cause hallucinations for the first time. Altered sensory perception, particularly visual spatial perception, hallucinations, behavior and mood symptoms, but they're also towards the moderate parts of the disease, you get changes in the autonomic body function. So they have problems with orthostatic hypotension, temperature regulation, postural control. They tend to fall a lot, bowel and bladder function. And very important, finally, these patients are exquisitely sensitive to medications, particularly those that affect the central nervous system. So that you have to use very small doses of medication. You have to use slow progression of doses, etc. and watch for side effects. Care of a person with Lewy-body dementia, it's similar to Alzheimer's type dementia in terms of decreasing stimulus, increasing rest, and promoting exercise, including big and loud programs which help the patients to breathe more deeply and their balance. Safety issues due to the REM sleep disorders and fall precautions are important. You cannot prevent falls in all of these patients. Supportive self-care activities and control of misleading environmental stimuli. Think of the television as your enemy because that TV is very often a huge trigger of hallucinations and delusions. And prepare the family for a response for potential aggression so that they have a plan. And then there is the Lewy-body Dementia Association and support groups. Next slide, please. With therapies, physical therapy, occupational therapy, recreational therapy have all been very, very helpful, plus pharmacist consultation on over-the-counter medications and prescription medications and how they interact. New paragraph, or I'm sorry, next slide, please. This is the resources. Next slide, please. Now we get to frontotemporal dementia or frontotemporal lobar degeneration. The best thing I can say about it is it's complicated. There are three common types. The first is, and most common, is what we call bvFTD, or behavioral variant frontotemporal dementia. It's sometimes referred to now as Pick's disease. You've got apathy, reduced drive, loss of executive function, inappropriate and impulsive behaviors, and very important, what we call anosognosia, which means that the patient has no insight into their condition, and even if their arms and legs fell off, they still wouldn't have insight or the ability to update their condition. The second is progressive language decline, and there's three different types, but basically the patient loses the ability to gradually to understand and use language. And progressive motor decline, which is much more rare, thank goodness. Things like frontotemporal dementia with ALS are fairly common. The patient will have what looks like behavioral variant dementia for a year or two, and then after that, they tend to develop motor symptoms and they pass on very quickly. Mixed dementias are common, but usually are diagnosed at autopsy. It is not uncommon, particularly in older adults who present with frontotemporal dementia, to have a mixture of Alzheimer's disease and frontotemporal dementia. And people with memory loss and FTD presentation sometimes can benefit from use with the anticholinergics. But Dr. Lance was right. You don't want to start an anticholinergic medication or a cholinesterase inhibitor, I'm sorry. You don't want to start a cholinesterase inhibitor in a patient with FTD as a general rule. New slide, please. These patients are often misdiagnosed. I completed a study of 68 patients, and we found that some patients went as long as 12 to 14 years without having a diagnosis because people kept giving them psychiatric diagnoses because it's so, the patients are young and it's hard to believe that they have a dementia. Very often these patients are labeled as late onset bipolar disorder, which there is really no such thing. If you see somebody with a diagnosis of late onset bipolar, you might automatically begin to think of someone with FTD. New paragraph. Or new slide, I'm sorry. People with Alzheimer's disease tend to worsen, have behavioral symptoms that worsen with progression, And with frontotemporal dementia, it's just the opposite. They tend to have initial more severe behavior problems that remain stable for a couple of years and then tend to actually improve a little bit. New slide. Again, the patient has loss of insight. Patients tend to exaggerate their positive personality qualities and minimize the negative. They have more problems with dominance, cold-heartedness, introversion, and ingenuousness. They're extremely challenging to care for, particularly because you can't reason with them at all, and they have no idea they have a problem. New slide, please. Staging, I'm going to let you read this, but you'll see that the mild has marked behavioral changes and in the behavioral variant. One of the things about frontotemporal dementia is that it tends to attack the brain more on one side than the other. So you can have the behavioral variant in the non-dominant side of the brain or the language variant in the dominant side of the brain. And as the disease progresses, the degeneration tends to move across the brain, so you get mixing of types. New slide, please. Some of the community-based interventions, you want a good diagnostic evaluation and hopefully a care team. If you look at www.theaftd.org, you will find places with resources all across the country for people with FTD. Follow up with social workers and advanced practice nurse for long-term care strategies and management, and also ongoing interventions that are pharmacologic and non-pharmacologic. Psychiatric assessment is very helpful with behavioral variant. Particularly, there are a number of these patients who will become quite aggressive, and a psychiatric admission is not uncommon. And then guardianship and conservatorship empower the family to make decisions. The problem is that when applying for an involuntary guardianship, this patient looks normal, they feel normal, they'll tell everybody they're normal, and when you send them for a neuropsych evaluation or any type of neurologic evaluations, they can pass the mental status test because mental status tests rely heavily on memory for their scores, and this patient has an intact memory. New slide, please. Other things, family needs to manage the patient's money, deal with driving issues, eliminate internet connections, because these patients will spend huge amounts of money. Taking steps to block phone solicitors, applying for disability and SSDI. Again, these patients are not 65 for the most part, although my average patient is right around 60. But they don't automatically qualify for Medicare and pensions, etc. And then explore using companion services for activities, because very often the spouse or partner is still working, and in many cases these patients still have young children at home, which is a whole set of problems unto itself. New slide, please. We use with these patients a palliative care approach. The average patient lives about 5 to 10 years with FTD, and so we're not going to use things like Lipitor and things that are going to hopefully work in about 10 years. We minimize the medications to only the essential. We try and get families into support groups, and there is one on Facebook for people who have no access to support groups in their area. Medic alert bracelet and tiles for tracking systems. Many of these patients become very hypermotoric, and what they tend to do is wander in their car, on their bikes, and then wander on foot. And so that can be a problem. We avoid activities that trigger obsessions. Obsessions are a very interesting part of FTD in that, excuse me, they are normal for the disease, and if you discuss it with the patient, why are you playing the piano one song for 18 hours a day, what they'll tell you is it helps manage their stress. So in Alzheimer's disease, what you might do is try and distract the patient. What you're going to do, if you can, with the frontotemporal dementia, is you're going to try and use those obsessions to keep the patient busy and engaged. And violence precautions. Many of these patients have violent episodes, and you have to get weapons out of the house. You're not going to tell the patient about it. Have a caregiver escape plan, and we insist that caregivers wear life alerts so that if they are trapped in a room or hiding in the basement or whatever, to keep away from the patient, they need some way to summon help immediately. So a life alert really works well. And there are any number of ones on the market right now. New slide, please. Again, repetitive behaviors serve a valuable function. They reduce mood or stress and help the patient remain calm and control the mood. Most common are motor activities with this. New slide, please. Okay, when we stage behavioral variant, the average lifespan after diagnosis is 5 to 7 years. The profound behavioral symptoms become apathy as the disease progresses, lack of sympathy, and severe disinhibition. Language disabilities, cognitive losses. The patient may be fully independent in basic activities of daily living. However, that does not necessarily mean they're going to bathe or shave for you. This is a patient who can become quite aggressive over issues such as bathing. And so we have the motto that no one ever died from not bathing. Late in the disease, this is a patient who may develop spontaneous vocalizations, which are not helped by medications, particularly the benzodiazepines will make the problem worse. New slide, please. Post-admission, if the patient goes into long-term care, large dining rooms ought to be avoided if it's at all possible. Monitoring intake for stuffing the mouth with food to avoid choking, stealing food from other residents, and eating non-food items. Many patients with Alzheimer's disease will essentially stop eating. People with FTD may stop eating, but very often they binge and will gain large amounts of weight. They need structured activities, but a flexible routine. If they're wandering and obsessive, we want to make sure they get calorie-dense foods and snacks, and encourage activities. But one of the things that people say is, why isn't John interacting with other people? That's part of the FTD. That's just a symptom. Focus on brief physical activities such as exercising, walking, dancing, and there is some research showing that painting can be very appropriate for these patients. And then psychiatric assessments periodically if the manipulation, sexual gestures, arguing, etc., present and get worse. New slide, please. Post-admission staff education is very important, particularly with the family. The family's been dealing with this. They sort of know what to do. I always worry when a family comes in and they say, we found a unit, and they deal with patients with FTD all the time, because sometimes we don't know what that means. Occupational therapy for personal care techniques, physician assessment for poor appetite, bowel movements, and behaviors. Sometimes these patients will develop pica and will eat things that they shouldn't, that are non-food items, including defecation, and so we have to be very careful about that. Next slide, please. Terminal care is similar to all dementias with terminal care. New slide, please. Okay. With primary progressive aphasia, the one thing I would strongly recommend is periodic speech therapy consultations, both for chewing and swallowing, for language production, whether the person can use adaptive devices, and also how much the patient is able to understand. New slide, please. In sum, as diagnostic specificity improves, non-Alzheimer's dementias are going to be diagnosed more frequently, and a one-size-fits-all program does not work for people with non-Alzheimer's dementias. So if somebody says to you, oh, FTD, that's the same as Alzheimer's, it's just dementia, this is a person who really doesn't understand. Families and care providers, as Sharon will tell you, are desperate for answers, ongoing support, and to seek out others suffering from similar conditions. Interdisciplinary care and research are critically important. Now I'm going to throw it over to Rebecca, who's going to talk about the most important thing, which is the families.
All right. Good afternoon, everybody. Great information so far, and I look forward to talking through, if you can go to the next slide, is an overview of what I plan to discuss today. Again, repeating some of what's been discussed, but just what is the impact or the implications on the individual and the family system when we look at the challenges they experience throughout the diagnostic process, the symptoms being less recognized and understood, more emphasis on that caregiver burden that Dr. Lance and Dr. Hall have addressed, young onset considerations, and then community resources. So if you can go to the next slide, please. So with the diagnostic process, as has been shared by our previous presenters, that misdiagnosis is very common. Frontotemporal degeneration is often misdiagnosed, again, as late onset mental health issues. I've heard a lot of sleep apnea misdiagnoses. Even one of our family caregivers shared that she had been told by her healthcare provider that she must be having marital problems, that she is making up the symptoms because her 46-year-old husband did not exhibit those symptoms when they were in the doctor's office trying to get the diagnosis. So she was told that she should seek counseling because they must have marital problems. So lots of misdiagnoses that we hear, again, as Dr. Hall said, late onset bipolar disorder. Until we finally get that diagnostic or that diagnosis, a lot of challenges emotionally for the family, not understanding the symptoms that are being expressed. But once that diagnosis is made, then we can see clearer in the rearview mirror why these symptoms have been occurring, that it is the disease process and not the person. But by that point, often there are consequences that have resulted. In many frontotemporal degeneration families, we see that there's been involvement with the legal system potentially, or a divorce has occurred because of these symptoms being misunderstood. Again, in retrospect, when we look back, that those symptoms are clear and they make sense. So there's often a sense of relief to get that diagnosis. Those negative or unfavorable behaviors are suddenly explained. And once we know what it is, as family members and providers, we can feel a sense of empowerment. Okay, now that I know what we're up against, I can learn about it, and I can, as a care partner, face the future with more confidence, learning about the disease process. And again, I greatly look forward to hearing Sharon talk about her experiences and how she has become empowered, and this has, in a sense, become a platform for her to connect with other families who are dealing with similar situations. support in the community is often very limited beyond Alzheimer's disease. Many dementia care programs and communities, adult day programs, et cetera, are set up on an Alzheimer's disease model, where you do see pockets around the country where there are more specific programs for Lewy-body, frontotemporal degeneration, young onset Alzheimer's. Those specific programs are often started at a grassroots level by impacted families or friends or support groups. So we do see some areas of the country have more resources, whereas others don't yet. And so that is always a challenge of helping family members get connected with others in a similar situation. Next slide, please. When we look at the symptoms, as Dr. Lance and Dr. Hall have described, these symptoms are less recognized. When many folks who have limited experience with dementias or non-Alzheimer's dementias, for many people, the word dementia equals memory impairment, but memory impairment may not be a factor with some of these non-Alzheimer's dementias, as has been described earlier. Particularly in frontotemporal degeneration, memory may be fine, and so the person may score well on traditional neuropsych testing that are more geared towards Alzheimer's disease. As the presenters have also described, with vascular dementia in particular, symptoms may vary depending on the severity of the damage and the area of the brain impacted. So when people use Alzheimer's disease as a reference point, these other symptoms seem more irregular. As has been discussed, safety considerations, because of that, safety awareness decreasing, the lack of insight into the disease process, safety becomes a huge concern for families and providers. So that is part of the symptoms of these non-Alzheimer's dementias in particular, that safety is a huge issue early on, and we're going to talk about resources and services in particular down the road. With the Lewy-body dementia, as has been described, these fluctuations in mental status, the falls, the hallucinations, these can all be very challenging for caregivers to manage. The mood disturbances and the physical increased care needs in vascular dementia, all of these symptoms in themselves being different than what we typically see in an Alzheimer's disease patient, that we have to give unique consideration to the different types of symptoms. Then with the frontotemporal degeneration, we may see legal implications. Again, someone may have encountered the legal system in some capacity. Oftentimes families need to seek out a elder law attorney to look at conservatorship or guardianship, as Jerry Hall presented. Financial implications, we'll talk about employment and social implications, which we'll discuss further here. If you can go to the next slide, please. So the nature of the symptoms for these non-Alzheimer's dementias tends to create extra challenges for the caregiver. Higher increased physical care earlier on in the disease process with vascular dementia, the language and behavioral changes in frontotemporal dementia, and then again these fluctuations. And something that I've seen with caregivers when talking with families and counseling them through caregiving with Lewy-body degeneration is when they don't particularly understand that these fluctuations are common, these cognitive fluctuations and the fluctuations in their ability to understand and comprehend and care for themselves, families tend to think, well, this person is messing with me. So an example that I've heard is a caregiver says, well, I said to my mother in the morning, let's have coffee and donuts, and she was able to swing her legs over the bed and get dressed fairly independently. And then in the afternoon, I am trying to get her off the toilet, and I'm saying stand up, and she looks at me blankly. So the easy misinterpretation of that is for families to say, well, she's just messing with me. this is just my mom and she's always tried to manipulate me. Well, that may be true, but this is different now. Now she has this disease process that is impacting her ability to respond at different times, and these fluctuations are common. So it's really important for us as support providers to explain the fluctuations and that this is the disease at this point, not the person. Additional high stress with caregiving, being a rare diagnosis. I can't tell you how many families have said when coming to a support group specific to frontotemporal dementia that they really appreciate connecting with others in a similar situation. Alzheimer's disease has its own set of challenges, but when a 40-something-year-old comes to a support group to talk about the symptoms of frontotemporal dementia and their loved one's impulsivity and erratic behaviors and maybe getting involved with the legal system, that's a very different set of circumstances than a 85-year-old person who is dealing with repetitive questioning. Again, not trying to minimize Alzheimer's disease, it's just a different sense of stress that these caregivers often experience. Also, because the age of onset with young onset Alzheimer's and frontotemporal dementia being younger, it's less expected. If we run into someone in a grocery store who is confused in their 80s, it's much more accepted than a 40-something-year-old who is undressing in public, and that is not as normalized. We start to think, well, this person has mental health issues, and so that burden on the caregiver is unique as well. What do families need most from us when they're dealing with caregiving for someone with all types of dementia, but in particular when we're looking at these non-Alzheimer's forms? What does the family need? First, they need advocates. They need advocates like us and advocates like you. They need recognition of the loss that they're experiencing, support and help with care, and respect and dignity for their loved ones. They are experiencing this loss. Their loved one is still there. They look maybe similar to the pre-symptom person that they were, yet they're noticing these changes over time and dealing with learning to navigate this illness. Next slide. With the young onset in particular, and I know I'm rapidly running out of time, so I'll fast forward a little bit here. The young onset, we have to think about the developmental stage of the family. There may be young kids at home, aging parents who people have, individuals who are getting that diagnosis and their care partners have been maybe previously considering care for aging parents, but now that this diagnosis has been made, we often see parents as caregivers for their children. So with Alzheimer's disease, we tend to see caregivers as a spouse or adult children. With younger onset, we often see parents now becoming that caregiver for their child. As Dr. Lance and Dr. Hall suggested, we do see potentially a stronger genetic component with younger onset forms of dementia, so that concern about genetics and what happens if I am also on the path to having this type of illness. As a loved one of someone with frontotemporal dementia or early onset Alzheimer's, the concern about genetics tends to be something that we hear quite frequently. With younger onset diseases also, the person with dementia who has been a earner maybe now has to stop working, and the caregiver who is also potentially needing to earn money is transitioning into a caregiver role as well, may need to consider family medical leave and other employment considerations. Next slide. As with any chronic illness, planning documents are needed. If those aren't in place, then conservatorship or guardianship may need to be explored. And just to repeat that, many caregivers may need to consider family medical leave and other resources as they transition into a caregiver role. Next slide, please. Often families who are dealing with these non-Alzheimer's types of dementia, they're often at the peak of their career and earning power, potentially thinking about retirement in the next phase of life, maybe raising the children, going to college, children leaving their homes. So they're in a different life phase, and then now they find themselves facing this deteriorating illness and knowing that increasing care needs are coming down the road. So the legal and financial implications are quite different than we might see in the traditional Alzheimer's patient who you see in your practice. With that, I want to highlight, and I have it copied here in the slides, if you can go to the next slide, that to be aware of this compassionate allowance initiative, which is a way to expedite SSDI and SSI disability claims, also expediting accessibility to Medicare benefits. This information was copied from ssa.gov, so you can find that information. I'll just leave that there for you. Again, the application process is no different than traditional application process, but because this FTD, early onset Alzheimer's, are considered, and many other conditions which you can find listed online, are considered these compassionate allowances, this would be something to refer families toward, again, to expedite accessibility to benefits. Next slide, please. For resources, support groups, and I think Sharon will underscore this, resources for families, support groups are great resources to connect with others in similar situations, not just from an emotional perspective, but also from a problem-solving perspective, for families to say, okay, well, I dealt with similar issues, and here's how I encountered that or managed that. Professionals like Dr. Hall, who can provide creative, non-pharmacological interventions and suggestions. Hopefully, support groups are going to be a great opportunity for families to get that support that they need so much. When we look at care models, again, as I said previously, with adult day programs and assisted living facilities, skilled nursing facilities, a lot of the care models are set up on Alzheimer's disease. So there may be a challenge in finding providers who have greater understanding of these non-Alzheimer's forms of dementia. But we have seen an increase in providers reaching out for more education. As Jerry referenced, bvFTD, the Association for Frontotemporal Degeneration, there are lots of resources related to FTD on their website, as well as the Lewy-body.org website. So there is information out there for providers. It's just a matter of getting that information into the right hands of the right people. Next slide, please. When family members are looking at planning for the future, the first step, and in your field as participants, as you are encountering families and individuals with non-Alzheimer's forms of dementia, helping them know the next steps is going to be very helpful. Knowing that it's a care team, not one person alone, determining what are their goals for care. And when we set out with knowing what the goals are early on, then we can use that goal as a guiding factor. So if our goals are comfort and safety, how do we make decisions based on using those goals as the guiding factor? Oftentimes when counseling families, I'll go back to that, okay, what are your primary goals? When we go back to those primary goals, it helps in making decisions. Okay, if safety is a primary goal and we're discussing out-of-home placement, well, safety at home is a big consideration because I've just got one caregiver, whereas if my loved one were to be in a memory care facility that is experienced in dealing with non-Alzheimer's dementias, then their safety would increase. So again, using those goals always as that guiding factor. Next slide, please. The challenge when we do consider other options out of home is that the person with non-Alzheimer's dementia doesn't always fit. The symptoms may be different. They may not fit in as naturally. The symptoms are different. They're younger, and not all facilities and programs are willing to accept and meet the needs of individuals with non-Alzheimer's type dementias. That is a challenge that we see across the country, is that this lack of awareness and lack of understanding when most professionals use Alzheimer's disease as the reference point. So understanding the disease process, learning more about the disease process is vital in order to meet the needs of these individuals. Also, as Dr. Hall mentioned, hospice care and the idea of palliative or comfort care for as a guiding philosophy. With hospice, we do tend to see denials for particularly folks with frontotemporal degeneration, because that criteria for hospice is geared towards Alzheimer's disease. So denials may be common for individuals who are younger, stronger patients. So again, it takes advocating for how does this person meet hospice criteria so that they can receive the benefits that they are entitled to use. Next slide, please, and I apologize for going over some best practices for home and community-based care. As I said, I do a lot of teaching around the country in facilities and day programs about how is care for someone with a non-Alzheimer's dementia different. Well, first is recognizing that it is different and that structure is very important. Tailoring activities to the person's ability, their past interests, and recognizing that they may not initiate activity on their own, but once given help to engage, they may actually engage in an activity once they are helped to get started. Unfortunately, the individual with frontotemporal degeneration tends to benefit more greatly with individual activities versus group activities. And then, as we all know, in a lot of the day programs and facilities, group activities are the norm. And so there's a challenge getting that person who is younger engaged in that activity who, and with that frontotemporal degeneration, they may not participate group-wise. They need more individual activities. And we see that they may relate more with the staff than they do with the older residents. With the younger onset dementias, we're going to see people relate more towards the younger staff members than perhaps the older Alzheimer's residents. I am going to transition to Sharon and look forward to hearing her perspective on, from a family perspective, and how we can all tailor our support for family members. Sharon?
Yes, my name is Sharon Hall, and I'm a full-time family caregiver to my 94-year-old mother who has vascular dementia and lives with us, and also my 64-year-old husband who has behavioral variant frontotemporal degeneration. And their symptoms are very different, and the biggest challenge for me, obviously, is my bvFTD husband, and I'll sort of be focusing on him today. I want to thank the previous speakers. You've all done a very good job explaining the earlier onset. There's some things that I would really like to point out to you. I feel that the hardest part of caregiving for those with any dementia is making that transition from a traditional role as a wife or a daughter to the role of a care partner. And I affectionately call Mom and my husband the twins. Once I was able to emotionally separate myself, my caregiving role became easier because it became less personal. And I think that's a really important thing for caregivers to do, to go through that ambiguous loss process that Rebecca was talking about. One of the biggest challenges in the earlier onset dementias is finding adequate care, as Rebecca was saying, whether it be home care, day centers, or long-term care. Day centers and long-term care facilities are usually filled with very aged Alzheimer's people. My husband is a healthy, robust, mobile person. His memory has no impairment other than some small short-term issues and some word-finding issues. His behavior is what can pose an issue for us. And although we have most of his behavior controlled with medication, when his anxiety goes up, he can still have outbursts when he's triggered. Also, since he presents as a very normal person to most people, they react differently when he displays behavior than they would with an elderly Alzheimer's person. People react to his dementia behavior as though it's deliberate in nature just because he's younger and healthy. That's one of the biggest challenges. Along with that challenge is finding a day center or a facility that has a younger population and activities that will interest him. Respite is an absolutely needed for family caregivers to continue to be a home care partner without burning out, especially with the more challenging behavioral dementias. My twins go to a day program for 2 5-hour days a week because basically that's all I can afford. It's not cheap. In-home care and long-term care can be an issue due to the disinhibition of FTD. They can say inappropriate remarks. People tend to, when they're caring for people with dementias, they have a tendency to hug and rub the backs of dementia folks. And with FTD, if you touch, be prepared to be touched in a like fashion. Hugging with an FTD person can also be a hug and a little of your backside if you're not careful. There's also what we in the FTD community call the look. And this can be interpreted by others as a mean look, and it can cause fear. I've never witnessed anyone with the look act aggressively due to the look. If aggression comes when you underestimate the abilities of the FTD person and treat them like a frail person whose memory is impaired, or you misunderstand their intent. Public situations can pose a very different set of challenges when behavior is an issue. My husband is fully aware of his diagnosis. His mother also had bvFTD. I initially carried some cards saying, please excuse my husband's behavior. He has a neurodegenerative disease, and please be patient. But I found that simply saying that to people who I encounter and he has behavior with, it gives us an opportunity to educate. And education in these other forms of dementia is so very vital and important. When my husband tells people I have dementia, they actually laugh because he looks and acts so normal. For those who professionally care for dementia folks, it really is imperative that you learn the techniques for controlling behaviors in FTD. PRN medications are not the only answer. They will work if you have escalated the incident to an uncontrollable level, but most behaviors can be managed with the right knowledge and practice before it gets out of control. At a late stage, all dementia looks very similar, but in early to mid-FTD, they are very different than the AD population. In early to mid-stage, asking them to assist with more advanced people really makes them feel needed and gets a really good response from them as well. Giving them purpose and not making them feel frail and incompetent is key to managing behavior in FTD, along with understanding where the behavior is originating from and being their advocate instead of their adversary. The financial burden, as Rebecca talked about, is enormous in the earlier onset. You do have someone in their 40s to 60s at onset, so you're looking at people who had to stop working in their prime working years. So their SSDI is far less than most Social Security recipients as far as their income. So FTD people are also very taken in by scams, and they buy extravagant things they do not need. They can blow through your entire life savings in 6 months if no one is watching. Many FTD spouses end up penniless for their own future care. FTD folks also show, as was mentioned, unusual eating habits. They can eat all one thing exclusively. They very often crave carbs and sweets. And as Jerry said, hygiene is an issue. They often refuse to shower or brush their teeth. And as Dr. Hall said, no one ever died from not taking a shower. So I would encourage people not to force those behaviors. If you force hygiene tasks, you can definitely trigger very unwelcomed behavior. So the medical community has a tendency to put all dementia in the same care basket as Alzheimer's, and that causes untold issues in the FTD population and their care partners. Each FTD person can show different symptoms, so listening to the care partner about how to handle their person is paramount to success. I recently attended a webinar by Dr. Alvin Holm, and these words stuck with me. You can't expect someone with a deteriorating brain, no matter their age, to live in your world with your rules. You must enter their world and accommodate your rules to their abilities. The best advice I can share is if they're not hurting themselves or others, let them do what they do. Let them pace, let them hump, bounce the legs, collect the rocks, sort the blocks, whatever helps calm them and what's happening in their brain. FTDers are square pegs in the dementia world. Try to remember not to pound them into your round holes for convenience of care. And that's really the best advice I can give to anyone caring for early onset dementia. I want to thank everyone for inviting me. I hope we've left you enough time for questions.
Wow, Sharon, thank you so much for sharing your experience as a family caregiver. And thanks so much to Melinda, Jerry, and Rebecca for your presentations. This has been incredibly informative. Thanks so much for joining today. So we have a few minutes now for questions from the audience. So at this time, if you have any questions for our speakers, please submit them using the chat feature on the lower left of the presentation. Type your comment at the bottom of the chat and press enter to send it. So Sharon, we just got a question for you, so I'll start with you. So the question is, Sharon, what kinds of techniques have you found that work best for your family members for managing behaviors?
I do a lot of apologizing. If I have triggered something and he begins to show behavior, I apologize. It's no skin off my teeth. It makes my life better. So I do a lot of, I'm sorry, that was totally my fault. I'm sorry. So I am on his side. Always being on his side helps diminish the behavior.
Okay, thank you, Sharon. Rebecca, we have a question for you. So the question is, can a healthcare surrogate with no family member present place a dementia patient in assisted living or long-term care if it's in the best interest of the patient legally?
Well, as we know, surrogacy and laws are different in every state. If a person does not have a family member who has been designated as a medical decision maker for them, and there is a legal guardian or conservator, they can make those decisions for the person.
Great, thank you. Dr. Hall, I'll move to you. We have a question for you. Do you have any suggestions for alternatives when access to psych services is a challenge?
This is very difficult. It's a national problem, too. I wish I could say, yes, we have all kinds of things. If your patient is a veteran, you might try the VA. But generally, looking at hospitals that have geriatric psych units or even just regular psych units may be your only options. Dr. Lance might be able to help with that more.
Yes, I mean, you can start with basic, any psychiatric unit can do a basic evaluation, but it's going to vary, in terms of how much insight and awareness that individual staff have. And some are great, and some simply don't have the trained staff to do it. I start with the basic services that are available in terms of medical and neurologic workup, and then you can try and go from there in terms of what you find out.
Thank you. And Dr. Lance, we have another question for you. Is frontotemporal dementia the kind that has been connected with frequent concussions or head trauma?
Oh, no. In terms of different types of dementias, the chronic traumatic encephalopathy type dementia has a different neuropathology. That's related mostly to neurofibrillary tangles. And it also comes with a different set of behaviors. The patients are younger. Often they've been athletes, so they're physically strong and healthy, and they have a lot of impulsivity often and fluctuating memory loss. It's also a very difficult type of dementia in that population.
Thank you. Dr. Hall, I'll turn to you again. So we have a question here. Are sensory rooms used to treat patients with challenging behaviors arising from dementia?
The snoozelen or sensory rooms are used in treating dementia. They've not been, well, nothing's been studied with frontotemporal dementia. It's one of those trying it. People with frontotemporal dementia are exquisitely sensitive to noises, to lots of visual input and overstimulation. So you have to be pretty careful with it.
Thank you. All right, and so Dr. Lance, I believe this will be another question that applies to you. So the question is frontotemporal dementia the dementia, oh no, I'm sorry, we just did that one. Here we go. Is early FTD, in early FTD, what techniques do we use to encourage treatment and diagnosis?
The best is good clinical monitoring and careful evaluation of the symptoms as they emerge, and try and mitigate behavioral problems. It's very clinically driven, and hopefully with a provider that can monitor the patient over time. We don't have a diagnostic test, unfortunately. And the use of PET scans early, I mean, they're limited availability. You may not be in a research center, and you're really dealing with a very clinically driven problem. And often people end up shuffling between primary care, neurology, and psychiatry. If you can stick with one provider who can monitor the patient over time, at least that can help and deal with the symptoms as they emerge.
Sure, thank you.
This is Jerry. Could I add one thing to that? Very often a family will be referred to a neurologist. It's important that the neurologist has behavioral neurology training. Because if it's somebody who likes to specialize in things like multiple sclerosis or strokes or that sort of thing, they may miss that diagnosis too.
Thank you. All right, so I think we have a question here that would apply to all of the faculty on our call today. What do any of the faculty know about a web-based tool called We Care Advisor that is geared to help family caregivers? Does anyone want to get started with that question? Is anyone familiar with the tool We Care Advisor?
I'm not.
This is Rebecca. I'm not familiar with that either.
Okay, we'll skip that question then. So how about this one? So you all stress the importance of the interdisciplinary team when supporting those with dementia and their caregivers. What community resources are out there to help with non-medical supports?
This is Jerry, and I imagine Rebecca can answer this too. We usually start with the Area Agency on Aging because they know of resources for dementia. We also start with the Alzheimer's Association if you have like a regional office in your area or a chapter in your area, because again, that's access to social services, etc. If the family needs to apply for medical help, etc., again, the Area Agency on Aging is usually a good starting place.
Yeah, and this is Rebecca. I would echo that as well. There are great national resources for frontotemporal degeneration as well as Lewy-body dementia. However, when you're looking at knowing local resources, we tend to turn to the boots on the ground professionals who are familiar with care at a local level.
This is Sharon, and I'd like to add to that local support groups for the various dementias are really a good source of information. Those of us that are doing this every day find resources and share them in those groups.
Great, thank you all for sharing. I think we'll have one final question before we turn to our closing remarks. So I've heard about something called dementia-friendly communities. How do I find out if there is one in my state? Does anyone on the line know anything about dementia-friendly communities?
I know a fair amount about it because we have one starting actually several in Tempe and Mesa, Arizona. Basically, they look at developing activities and resource places for people with dementia that use the arts, they use music, they use painting, they use all kinds of things. They have a coffee shop where people can get together who have dementia. Again, they're based on an Alzheimer model, which is shorter activities, less stress, and the development of social relationships. A person with Lewy-body dementia can very often be quite successful in these programs. Somebody with behavioral variant FTD or language variant FTD would have a much harder time because of the difficulty of interacting with individuals who are not able to participate in conversations, have no empathy, that sort of thing. So you would find out about it through your area agency on aging, again, as your first place to start. Also, I'd call the local newspaper and see if they've done an article on dementia-friendly communities and if there is one in your area.
Thanks, Dr. Hall. And with that, we'll have to turn to our final remarks. Any questions that we didn't have time to address today, we'll post to our website in the form of Q&A. If you do have any additional questions or comments, you can email us at ric@lewin.com. The slides for today's presentation, a recording, and a transcript will be available on the Resources for Integrated Care website shortly.